Assalamualaikum and greetings. I am Shafi Amiti Bakaruddin and with my colleagues Nurul Shafiza Shamsuddin. And for this video, we are going to discuss and share about critical appraisal of case control and cohort study in evidence-based practice. Before discussing on critical appraisal and specific study of cohort and case control, let's discuss about evidence-based practice first. Evidence-based practice, EBP, is a problem-solving approach to the delivery of healthcare that integrates the best recent evidence from studies and patient care data with clinician expertise and patient preference and values. Research studies shows that EBP leads to higher quality care, improved patient outcome, reduced cost, and greater healthcare provider satisfaction than traditional care. Despite these favorable findings, many healthcare providers remain inconsistent in their implementation of EBP in providing care. Some healthcare providers may feel that EBP is too difficult and time-consuming. Therefore, here we simplified the steps of EBP into 5 simple steps. It starts with ask, where firstly, we convert the information need into an answerable question. We can do this by using PICO framework, P for patient, population and problem, I for intervention, C for comparator, and O for outcome required. Secondly, acquire. We need to acquire or find the best evidence to answer the question. This can be from primary, secondary or tertiary evidence, from online database, textbook, guidelines and so much more. For the third step, we need to appraise. This is what we will be focusing on today, on how to critically appraise the evidence for validity, impact and applicability. And the fourth step is we apply the evidence by integrating the evidence into clinical decision making. Finally, we audit the process where we need to evaluate the step from 1 to 4 and seek to improve next time. Let's look to the evidence. Is all scientific evidence the same? There is a kind of ranking for different types of study design. Level of evidence is based on quality bound to different design. For example, cohort study is more superior than animal and in vitro research. The highest level of evidence is dominated by randomized control trial, systematic review, and meta-analysis. So this is an example of a research article which is an evidence. So for this study, we can actually frame the study into a PICO framework, looking at the P, the population or problem, which is the obesity children 8 to 16 years old. The I for intervention is clearly the metformin. The C for comparator is the placebo, and the outcome is the weight, body mass index, C-reactive protein, blood pressure, and also triglyceride. So what is critical appraisal? Just like what we mentioned before, a critical appraisal is a process of carefully and systematically assessing the outcome of scientific research or evidence to judge its validity, trustworthiness, and value and also relevance. For validity, we will be looking if the research or evidence has a clear objective by defining population of interest, intervention and outcome, the PICO model. And we will also be looking at if the study have appropriate methods, were the methods appropriate to answer this question, and if relevant participants included, and how is the selection of participants. So we'll be looking at this for validity. For trustworthiness, we will be assessing if the findings were clear and justified, and was the data analysis rigorous, like was it done properly according to pre-specified protocol. And for value and relevance, we will be looking at how practical relevance of the finding, and if all important outcomes were considered and can it be applied locally. means the local relevance of the study. There are several critical appraisal model available, such as the scales, which lists of item with scales that create scores, such as the JADAT scale. A checklist with logical and structured approach to assess methodological quality, such as CSP, JPI, and so much more. Also domains, which focus on specific elements that might adversely affect internal validity of a study, such as Cochrane risk of bias tools. Okay, this is an example of scale types critical appraisal model, which is a very common and old one, which is the JADAT scale. Next, we have the checklist model. This one is the CASP, the Critical Appraisal Skill Program from UK. But there are also other checklists such as the Oxford, BMJ, JBI, and so much more. And here is an example of tools that use domain model. In this one is the Cochrane risk of bias tool, which is usually used in systematic review and meta-analysis. So why critical appraisal is important? So actually it's an important skills in evidence-based practice, as it shows the extent of knowledge on study design and allow reviewer to identify bias and reliability, as well as judging the practical relevance of the research finding. So for today's video, we will be focusing on two types of study, which are the cohort and case control study. Let's start with cohort study. So what is a cohort study? It is an observational study in which we only observe throughout the study without providing any intervention. And the subjects are sampled based upon presence or absence of exposure, and then their subsequent disease cause is studied. So we actually proceed from cause to an effect. So samples are being followed up from exposure until the end outcome. So in cohort, one way to measure the outcome is by using relative risk. Relative risk measure the association between the exposure and the outcome. It is a ratio between incidence of outcome in an exposed group over the incidence of outcome in unexposed group. So relative risk less than 1 means lower risk, equals to 1 means no risk, and more than 1 means higher risk than the unexposed group. As with other study design, we can expect some advantage and disadvantage of cohort studies. For the advantage, cohort will allow study of rare exposure and multiple outcome, because we are looking from exposure to outcome. So we can choose a cohort of rare exposure and able to observe multiple possible outcome. So it will also allow for time to event analysis and establish population-based incidence, as we can detect new cases from the outcome. There are also some disadvantages because it is usually required large sample size and long period to follow up. This leads to potentially loss to follow up. The cost is also usually more expensive, and other than that, it's also not suitable for rare or long latency disease such as cancer or rare diseases. So for today, we will be doing a critical appraisal of this study on metformin associated with a lower risk of TB in patients with type 2 diabetes by Lin et al. So for the critical appraisal, we are going to adopt a critical appraisal checklist for cohort study by JBI, which is a Joanna Briggs Institute from University of Adelaide, South Australia. So this is the article which was published in Clinical Journal of the Asian Pacific Society of Respirology in a well-recognized online database on Wiley Online Library. So for the first question, we are looking at were the two groups similar and recruited from the same population. So for this study, the population was taken from National Health Insurance Research Database in Taiwan. So this study enrolled patients who are 20 to 100 years old who were newly diagnosed with type 2 diabetes between 1998 to 2010. Because the baseline characteristic and diabetes severity might vary between metformin user and non-user in the original unmatched cohort, the one-to-one propensity score match analysis was conducted. For metformin user and non-user, propensity score was calculated to estimate the probability of metformin use. So, case and control of the cohort was matched using propensity score with the covariates such as age, group, sex, region, socioeconomic status, comorbidities, and diabetes mellitus complication. So the answer of the question is yes. Let's go to the next question. So the second question is, were the exposure measured similarly to assign people to both exposed and unexposed group? So for this study, metformin exposure was measured through NHIRD database that include data of prescription drugs. However, the measure of exposure was not mentioned in detail. It was only mentioned that metformin users were enrolled in the study cohort on the date after their prescription of metformin. If the question asks if the measured similarly, so the answer is still yes for this study. For the third question, was the exposure measured in a valid and reliable way? It is a yes because the exposure was measured in by detecting metformin in the NHIRD prescription record as an anatomical therapeutic chemical code or ATC code with a specific code of A108A. So let's go to the next question. So the question 4, were confounding factors identified in the study? So for this study, the study mentioned age group, sex, region, socioeconomic status, comorbidities, and diabetes mellitus complication as covariates instead of confounding factors. The study also clearly identified smoking history, environmental exposure, body mass index, and glycemic control status as confounder, but these factors were not measured as they were not available in NHI report. So, for the question if the confounding factors are identified, the answer for this question is yes. Let's move to the next question. So for the question 5, were strategies to deal with confounding factors stated? For this study, to reduce the effect of confounding factors, the study exclude individuals with confirmed active TB, history of malignancy, and HIV infection prior to the diagnosis of type 2 diabetes mellitus. And the study used propensity analysis by using logistic regression to obtain a propensity score match for each patient with covariates of metformin user and non-user. So the study also applied adjusted proportional hazard assumption and proportional hazard model to analyze the effect of single and multiple covariates on predicting whether TB would develop. So the answer for this question is yes. Looking at the next question, were the groups or participants free of the outcomes at the start of the study or at the moment of the exposure? So for this study, the participants were free of the outcome at the moment of exposure as the study clearly exclude any sample with confirmed active TB prior to cohort recruitment. So the answer for this question is yes. Moving to the next question, question number 7. Were the outcome measured in a valid and reliable way? So for this study, outcome of active TB patients were validated by the Center for Disease Control and Prevention, Taiwan, as TB is a notifiable infectious disease, and physicians are required by communicable disease control to report all patients who have suspected or confirmed TB to the government. So active TB was clearly defined as at least one outpatient visit or one hospital admission with international classification of disease 9th revision, clinical modification of ICD-9-CM code for TB, in NHR records during the follow-up periods, and the prescription of more than 2 anti-TB medication for more than 90 days during the study period. So the answer of this question is yes. So the next question was the follow-up time reported and sufficient to be long enough for outcome to occur. Previous studies mentioned did for 3 months to 5 years follow-up of cohort for tuberculosis outcome in diabetic patients. Therefore, duration of 12 years follow-up in this study is considered sufficiently long to monitor tuberculosis outcome in this cohort. So the answer of this question is yes. Moving to the 9th question, was follow-up complete, and if not, were the reason to loss to follow-up described and explored? For this, the study used retrospective study design for tuberculosis outcome measurement follow-up in the cohort. Therefore, the follow-up measurement were completed as it is being done retrospectively. So the answer is yes. For the number 10 question, were strategies to address incomplete follow-up utilized? Since there is no loss to follow-up and the study used retrospective study design for to measure the outcome, so there is no incomplete follow-up, and the question is not applicable for this study. So for the last question, was appropriate statistical analysis used? And from our review, the appropriate statistical analysis were used as the continuous variables were analyzed by t-test and categorical variables were analyzed using a chi-square test. To confirm the association between TB incidence and metformin use, a time-to-event analysis was also used to estimate the probability that an event would occur at different points in time. The most common time-to-event statistical method are Kaplan-Meier analysis and the proportional hazard model. Kaplan-Meier analysis were performed to estimate the difference in the risk of TB development between the cohorts. So, the proportional hazard assumption and proportional hazard model was applied to analyze the effects of single and multiple covariates on predicting TB incidence. So, the answer of this question is yes. So as a conclusion, there is also this part at the end of the checklist where we can actually comment for the overall appraisal of the study. So the study was acceptably large, comprehensive, and nationwide analysis using appropriate statistical measure to assess the risk of tuberculosis in metformin user and non-user of type 2 diabetes mellitus population. So the study also used retrospective design, so it prevent any loss in follow-up and use propensity score matching to reduce the effect of confounding factors. However, due to the retrospective design, the accuracy of the study is not as accurate as the prospective study. Despite of that, the result was significantly useful as it took 12-year-long follow-up, which may be less or not very feasible using a prospective design. So for the overall appraisal of this paper, we conclude that if we are taking this into a systematic review, so we'll be including this study in our review.
Case control study is a type of observational study In a case control study, it starts off with cases. These are people with a disease, and a comparison group called controls who are similar to the cases but do not have diseases. In case control study, data regarding past exposures to possible etiologic factors in both groups are obtained. The frequency of exposure of both groups will be compared to determine if an exposure is associated with an outcome. This permits estimation of odds ratio. An odds ratio is a measure of association between an exposure and an outcome. How to calculate odds ratio? Odds ratio represents the odds of exposure in cases compared to odds of exposure in control. Odd ratio more than 1 means that people with disease are more likely to have been exposed to that risk factor than people without the disease. This suggests that it could be the possible cause of the disease. Odd ratio less than 1 suggests that it is a protective factor, and odd ratio equal to 1 suggests no association. There are two sources are commonly used to select the subject. It's either general population or hospital population. In the general population, the subject can be selected via same geographical area, survey, or registry. While in the hospital population, the subject can be selected from one hospital or a network of hospitals, or admission during specified times. Hospital population is more convenient as the exposure information can be collected from medical records and biological specimens. In a case control study, matching is very important. Matching is the process of selecting controls so that they are similar to the cases in regards to certain characteristics to avoid confounding. Matching can be done by same gender, race, and also age. Major advantages of case control study is that they are often quick and cheap to do. Also because they start off with cases, it can be used to study rare disease and multiple exposures. However, because this study involves small number, they are not good to study rare exposures. Case control study also are not useful to study multiple outcomes and has potential bias such as selection bias and also recall bias. Now, we will try to critically appraise the case control study by using CAPS checklist. We will look into study titled Eczema and Subsequent Suicide, a MASH case control study. Did the study address a clearly focused issue? The answer is yes. The study considered the association between eczema and a patient's subsequent risk of death from suicide. They contextualized these research questions against the observation that eczema is associated with reduced quality of life, which is common with many chronic conditions. The previous research also has linked eczema with psychiatric illness. Did the author use an appropriate method to answer their questions? The answer is yes. In this case control study seemed appropriate method as an experimental study not feasible to randomly allocate people to have eczema and because the outcome of suicide is relatively rare. Were the cases recruited in an acceptable way? In this study, cases are classified from coroner's reports, which appears to be reliable means of classification. So the answer is yes. Were the controls selected in an acceptable way? Yes, controls selected from general population samples using the registered person databases that identifies all patients insured under Ontario Health Insurance Plan. Besides that, cases were matched with controls on age, sex, and socio-economic status, which strengthened the robustness of this study design. Was the exposure accurately measured to minimize bias? Yes, the study used health records to detect exposure. However, authors discussed difficulties in classifying and identifying persistent eczema. They also acknowledged the possibility of misclassifying persistent eczema. Aside from the experimental intervention, were the group treated equally? Yes. Have the authors taken account of the potential confounding factors in the design and in their analysis? Yes, author attempted to account for the effects of confounding by matching the cases and controls. Author also stratified cases and controls by other relevant suicide risks, such as depressions, to see if the association between eczema and suicide can be explained by this other risk factor. How large was the treatment effects? The odds ratio of the association between persistent eczema and suicide was 1.22. Thus, there is a small increase in risk. How precise was the estimate of the treatment effects? The odds ratio with 95% confidence interval is between 1.01 to 1.48. Do you believe the results? Yes, the result was statistically significant with considering other confounding factors and good study design that reduced the risk of bias. Can the result be applied to the local population? Yes, the result can be applied to the local population where physicians can have opportunities to intervene for suicide prevention in these vulnerable eczema patients populations. Do the result of this study fit with other available evidence? Yes, the result of these studies is in agreement with other studies conducted in Norwegian and Denmark, where both of the studies shows association of eczema with risk of suicide ideations or attempts among eczema patients. What are the differences to critically appraised cohort study and case control study using CAPS checklist? Before I explain about it, let's recap the differences between cohort study and case control study first. Cohort study is a longitudinal study that observes the causes of disease and investigates the relationships between risk factors and health outcomes. It can be either prospective or retrospective. In cohort study, it proceeds from the cause of disease to its effects, while case control study is an observational study that compares two groups of people, those with the disease known as cases and very similar group of people who do not have the disease known as controls. It can be conducted retrospectively only. In case control study, it proceeds from the effects of the disease to its cause. So what is the differences in CAPS checklist for both study? In cohort study, we want to check whether the cohort recruited in an acceptable way, while in case control study, we want to check both cases and control recruited in an acceptable way. Besides that, in cohort study, we need to check about the follow-up of subjects, whether it's complete enough and long enough for the study, while in the case control study, we're concerned about the both groups treated equally. Lastly, for the result of study, in cohort study, we will check the relative risk, while in case control study, we will look into the odds ratio.